This meeting has been started and the recording has been begun as well. Palmetto GBA has previously announced that it will record the open meeting, and Palmetto GBA consents to this recording. So I have just started the recording of this open meeting in compliance with CMS. For the record, prior to doing so, I have announced that Palmetto GBA would make an audio recording of the open meeting and consented on behalf of Palmetto GBA. The objective of the open meeting is to provide an open venue for stakeholders and interested parties to comment on a proposed LCD. The presentations are summaries of the comments. Due to time constraints, may not be comprehensive in all concerns. Presenters are asked to submit written comments and any supporting established peer-reviewed literature by July 14th, 2024 to either a.policy@palmettogba.com or b.policy@palmettogba.com, which will be addressed in detail in the response to comment article. Presenters will each have 15 minutes, and at the conclusion of that time will be muted and the next presenter will be promoted. Please be mindful of your allotted time frame to ensure that you can share your closing remarks before your time concludes. Out of respect for the presenters, I'm asking that everyone who is not presenting, please mute and turn off your cameras. Thank you very much, and we will get started. Our first presenter today is Dr. Gagan Sawani. I hope I pronounced that correctly. They are presenting from Georgia Eye Partners, and they are presenting on micro-invasive glaucoma surgery, MIGS, which you can find by referencing DM 37531. Thank you very much for being here today, sir.
Hello, thank you. Once again, good afternoon. My name is Gagan Sahani, and I am a cataract and glaucoma specialist based out of Atlanta. I'm here today on behalf of several ophthalmology societies to discuss Palmetto's proposed LCD for MIGS. I am a speaker for Alcon, AbbVie, and Sight Sciences. First and foremost, we'd like to express our appreciation for working with the Contract Medical Director Workgroup over the last year on this policy. The public comment process has resulted in a proposed LCD, which overall reflects current practice patterns and allows physicians and patients to come to treatment decisions that work best for that unique patient. As I like to tell my staff, my team, my patients, the same tool does not work for every patient. We also appreciate the addition of the section on healthcare disparities, which highlights the disproportionate disease burden of glaucoma on minorities, especially African Americans and Latinos. Being based in Atlanta, a city with a large African American and Latino population, I see the burden of the glaucoma every single day in my clinic. People are losing their vision, losing their ability to work or drive, losing their independence. We need to help them out. More research is needed to better understand differences in treatment, and that future research must include more diverse study populations. Our societies appreciate the opportunity to present today and offer a few additional recommendations to further improve the proposed policy so that all glaucoma patients may be afforded access to the treatment that best suits their situation. We agree with the proposed coverage of stents described in the indication of coverage 1. For 2, it's probably just a typo, but we want to note that the correct terminology is subconjunctival, not supra. The device is drain fluid or aqueous from the anterior chamber into the space under the conjunctiva to reduce pressure in the eye. While phacoemulsification with a single MIGS procedure is indicated as covered in the limitations of coverage section, for clarity, we think that it makes sense to include it in the indications of coverage section. We recommend using similar coverage language already found within the LCD and creating a separate number 3 bullet as shown on the screen. Phacoemulsification intraocular lens placement can be performed with a single MIGS procedure. Next slide. As a result, corresponding changes to the limitation of coverage should be made. For limitation 2, we ask just for a slight clarification. We recommend changing patient to eye because glaucoma can be bilateral. It can impact each eye differently. Sometimes each eye behaves very differently from each other. For consistency and clarity, we recommend that limitation 3 read phacoemulsification intraocular lens placement performed with a combination of MIGS procedures, e.g. cataract, stent, canaloplasty, goniotomy, at the same time of service in the same eye is not covered. The intent remains the same, non-coverage for multiple MIGS procedures with cataract surgery, but this language will be more clear for physicians and coders when referencing. Next slide. Although we understand what limitation 3 is in policy at this time, our organization calls your attention to the growing body of evidence that shows improved outcomes and patient experiences when MIGS procedures are combined. I want to step back just for a second. People with glaucoma still lose their vision despite our best efforts. The question is why? It goes back to compliance. People have trouble taking their medications. It could be tolerability, cost, dexterity issues, cognitive issues. They just can't remember. The more topical drops we continue to add, the less likely they are to take their medications. To be fair, many of us, including myself, have trouble taking a daily multivitamin. A 2023 study by Dickinson found significantly greater reduction in glaucoma medications while maintaining similar rates of IOP reduction and low complications when cataract surgery was combined with multiple MIGS, microstent and canaloplasty, compared to just cataract surgery and microstent alone. The next question is, why do we want to combine MIGS? There are multiple obstructions when we think about fluid flowing out of the eye. We want to address all of those obstructions. Each MIGS targets a different level of obstruction. In this case, the microstent physically keeps the canal open, and the canaloplasty dilates the entire canal and opens up those distal outflow channels so that the stent is more effective. In my opinion, this is phenomenal, innovative, and a safe way to preserve vision by reducing intraocular pressure and helping with compliance by removing the drop burden on the patient. Reducing glaucoma medications not only improves the patient experience, but eliminates cost, burden, and potential side effects of daily eye drops. And it also can reduce healthcare costs. Many patients, especially elderly patients, have poor compliance because they struggle with dexterity, cognitive issues. Additionally, ocular irritation caused by glaucoma medications can significantly impact vision and overall quality of life. Medicines are not benign. Topical medicines are not benign and can impact cardiovascular and pulmonary function. We understand that although there is currently not enough evidence for combining MIGS as a standalone procedure, we expect strong evidence to grow. We feel it's important for a surgeon to have this option in their toolbox for patients who may benefit from reduced or eliminated. We appreciate the list of definitions included in the LCD because it helps everyone speak the same language. With that goal in mind, we encourage you to update the definition of refractory glaucoma to align with the definition agreed upon and established by our societies in our 2021 consensus statement. Just to repeat it, when the intraocular pressure remains above target values selected to slow or halt the disease, despite the use of multiple classes of medications, or, and this is also important, fewer medications when tolerability or effectiveness limits the use of other drug classes. While similar to the proposed definition, we feel that the additional specificity in the consensus statement reflects how we as glaucoma specialists think about the disease. This particular definition focuses on medical treatment, and we agree with your proposed definition that the failure of surgical treatment should be included. Next slide, please. In summary, patients with glaucoma, which disproportionately affects Blacks and Hispanic patients, need access to a range of surgical procedures. We need to tailor our treatment to the patient. As I mentioned earlier, the same tool does not work for everyone. Our organization appreciates that this is generally recognized throughout the proposed LCD. For many patients, treatment with medication is inadequate and their glaucoma is not at a stage requiring more invasive procedures such as a trabeculectomy or a tube shunt. For these patients, MIGS helps preserve the quality of life and reduce total cost of the healthcare system. Trabeculectomy and tube shunts, while really good at lowering pressures, have a very high risk profile. Even if performed technically perfectly, there's risk of hypotony, devastating eye bleeds, and infections. We support further studies to investigate the indications of combining phacoemulsification, intraocular lens placement with more than one MIGS procedure. Cataract plus stent, canaloplasty, or goniotomy. The goal of this is to create synergy by addressing multiple different aspects of outflow. We ask that carriers expand coverage when more outcome data become available. We look forward to continuing this dialogue and will be submitting formal comments with PDF copies of studies on multiple MIGS procedures combined with phaco-IOL. I want to just say thank you for your time and consideration of these recommendations. We believe they will lead to improved patient care and outcomes. We want to keep our patients seeing. We want them to maintain their independence. Thank you.
Thank you, sir. I appreciate your excellent presentation. And our next presenter will be Dr. Frank Corrigan from Wellstar Health System. Dr. Corrigan, I do apologize for the mix-up in the order of the presentations today, and I thank you for your patience. Dr. Corrigan will be speaking on artificial intelligence-enabled CT-based quantitative coronary topography, AI-QCT, coronary plaque analysis, AI-CPA, which can be referenced by looking for the DL39851 proposed LCD. Thank you very much, and we're ready to hear what you have to say, Dr. Corrigan. Thank you.
All right, thank you so much. I'm Frank Corrigan. I'm an interventional cardiologist at Wellstar, and I wanted to briefly discuss AI coronary plaque analysis, which I think offers a fantastic improvement in our ability to risk stratify our cardiovascular patients. So coronary artery disease is increasing in both prevalence and cost. And the total cost burden is expected to reach over $350 billion by 2023. Despite innovation in lipid-lowering therapies and advances in our cardiovascular procedures, heart disease remains the leading cause of death in the US. Importantly, most cardiac events occur in patients with non-obstructive coronary artery disease. More than 10 million stress tests are ordered every year, which are designed to only detect obstructive coronary artery disease. So in our therapies and in our procedures that we offer our patients, we're not being as comprehensive as we could be. The idea of looking at coronary plaque is a relatively newer concept, but what we're talking about with this LCD is providing coverage for a plaque analysis that actually quantifies the plaque that patients have in their coronaries, dividing it out into calcified, non-calcified, and low attenuation plaque. This has been shown to correlate with the patient's risk and also allow us to give patient directed care based on their imaging instead of using population-based risk scores. For example, a total plaque volume greater than 240 has a hazard ratio of 7.3, increased risk of myocardial infarction. Additionally, a low attenuation plaque burden greater than 4% is also associated with a higher risk of non-fatal MI. Additionally, breaking coronary plaque down by whether it's non-calcified, low attenuation, different thresholds increase a patient's risk. So, for example, a total plaque volume greater than 560 based on this advanced registry shows the patient has an increased risk of cardiovascular events. Again, a non-calcified volume greater than 320 is associated with an increased risk of events. Additionally, just having a low attenuation plaque volume greater than 10 cubic millimeters increases a patient's risk. I think it's best to understand this through an example. This is a patient of mine who is a 50-year-old man who had hypertension and was developing chest discomfort when exercising for the last 5 weeks. He was on no medicines. Here are his vitals. His blood pressure is 135/89. Here's his lipid profile, mildly elevated. He does not have diabetes. Based on the traditional population-based risk scores, using this information, his 10-year risk of MI or stroke is 5.6%. The American College of Cardiology promotes this risk score to be used to help understand who needs preventive therapies. Using his risk, which is heavily dependent on age, he's in the maybe consider a statin group. When that's greater than 7.5, you do consider a statin. That said, he has typical symptoms. So, we might have a different approach. Go forward. Using a coronary CT, we see that he has a critical proximal LAD lesion. Importantly, his calcium score is 0. So here is a 50-year-old man with a 0 calcium score and a 10-year ASCVD risk of 5.6%. if we use this AI-based coronary plaque analysis, we can learn so much more about this patient and treat him more effectively. He has a total plaque volume of 196. 13% of this is low attenuated, and you see it's 26 cubic millimeters, which is elevated risk of events based on analysis from the advanced registry. Additionally, these plaque analyses have been adjudicated with a nomogram of over 13,000 patients. And based on his age and gender, he's at the 71st percentile, which using this information allows us to understand this patient is much higher risk, and this is dedicated just to this patient as opposed to using population-based risk scores. Think about this globally. When we look at calcium scores, a patient with a calcium score greater than 300 has equivalent risk of patients with known cardiovascular disease. So in a sense, plaque or just looking at calcium scores is a better predictor of a patient's risk than these population-based risk scores. Finding disease is more important than just finding obstructive disease. Obstructive disease is what we find on stress tests. And yes, finding obstructive disease is associated with increased risk over finding no or non-obstructive disease. However, if you click the slide, there's an animation. However, if we stratify obstructive and non-obstructive disease by a patient's calcium score, essentially their plaque burden, there is no difference in the combined incidence of MI and major adverse cardiovascular events. So in other words, having disease in the coronaries is more important than just determining if a patient has obstructive disease. If they have a large volume of plaque, those patients are high risk, regardless of whether or not they need revascularization. So what we've been able to do with coronary CT is first determine if a patient has physiologic significance in a specific lesion with FFRCT. Now what we're able to do is, in addition to determine physiologic significance, also analyze the plaque. So this is a little bit of a complicated slide, but patients with abnormal FFRCT and either a small volume of plaque or a high volume of plaque in this red dotted circle have increased events soon. Patients with plaque but non-flow limiting lesions are at increased risk for major cardiovascular events, but it comes at a later time. So physically seeing the plaque allows us to get these patients on preventive therapies sooner. Additionally, we can track disease progression and changes in plaque volume. Patients who are on statins have reduced rates of progression of plaque. Additionally, patients who are on statins have increased rates of turning the plaque into calcified plaque and a better rate of the calcified plaque or the plaque becoming less non-calcified. And in other words, if we follow plaque progression with coronary CT based on these plaque analyses, we can follow the change in plaque from calcified, which is actually low risk, to non-calcified, which is high risk. So how do we do this in a real world environment? A patient gets a coronary CT rather than a stress test. If they have plaque, we're able to provide a PROC analysis, which further provides risk assessment and allows us to tailor our preventive therapies to the patient. Additionally, we can put this in a population context by the nomograms, which give the patient a percentile based on their age and gender. We can then determine a patient's risk based on their based on the nomogram, based on their plaque volumes, based on their low attenuation plaque volume, and then we can provide appropriate preventive therapies based on what we see. Next slide. Brief example, patient A, patient B. Patient A has physiologically significant lesions based on their FFRCT analysis, and thus has a high risk of near-term adverse cardiovascular events. Patient B has no physiologically significant lesions and therefore has a low near-term risk of major adverse cardiovascular events. Next slide. Using the plaque analysis, we can learn a little more about this patient. Patient A, who has an obstructive lesion, has a smaller plaque volume than patient B, who has nearly 591 cubic millimeters of plaque in the coronaries. Therefore, patient A has a low long-term MIGS risk based on their percentile, which is 20%. And patient B has a high long-term MIGS risk. So patient A might need a cardiac catheterization and might need a stent or bypass, some sort of revascularization. And then that might take care of that acute episode and then can be monitored further for risk prevention. Patient B needs very aggressive preventive therapies at present to reduce their risk of having much worse events later on. So what is our ask? The current LCD reflects the current literature and is comprehensive. However, one thing that we think needs revision is the fact that it says that it's written for patients with acute chest pain and no known coronary disease. We'd like to update this language to include patients with either stable or acute chest discomfort. Every example that we showed was based on patients with stable chest discomfort. And I think that the plaque analysis is most appropriate for use in patients with stable symptoms, as it's more directed toward patients with needing preventive therapies. Again, this would be in keeping with the current AHA and ACC guidelines, which advocate for plaque to be used in both populations, patients with acute chest discomfort and stable chest discomfort. And with that, I hope that we can see the value of analyzing patients' coronary plaque to help drive patient-centered care. And we appreciate the MAG's consideration of AI-CPA, and I hope that we can update the language so we can help our patients more appropriately. Thank you.
Thank you, Dr. Corrigan, and thank you again for being patient with us with these switches.
No problem. I had a maintenance crew come into this room in the presentation. So
I apologize that we interrupted your scheduled afternoon. On behalf of Palmetto GBA, as we have finished our presentations for this afternoon, I would like to thank both of the presenters for their excellent presentations, very informative. And I would remind everyone that all written comments and supportive literature need to be submitted by July 14th, 2024. I wish everyone to have a wonderful afternoon and a good rest of the week. And we will now end this recording. Thank you very much and have an excellent Monday.